Good afternoon and welcome to our breakout session, Opioid Use Disorder, Consideration of Medication-Assisted Treatment for Real-World Challenges During the Coronavirus Pandemic. This is Doug Edwards. I'll be moderating the session, and this session is supported by an educational grant from Indivior Inc., an addiction professional. And I'm delighted to introduce this afternoon's speaker, Dr. Mark Fishman, who is with Maryland Treatment Centers, Mountain Manor, and Johns Hopkins University School of Medicine. Just a friendly reminder that on the right side of your screen, you can ask questions, which we will ask our speaker at the end of the presentation. Without further ado, Dr. Fishman, the stage is yours.
Well, thank you so much, and good afternoon, everyone. It's a pleasure to be here with you. I hope you're having a good conference so far. Not that it matters in a virtual conference, but I'm sitting here in Baltimore, Maryland, which is where the conference had originally been scheduled to be if it weren't virtual. So hope we get to welcome you back here in future years. And I'm going to be talking about opioid use disorder, or OUD, and some of the interesting areas of impact of medications for opioid use disorder, MOUD as it's sometimes called, or MAT, medication-assisted treatment. And I'll be talking about some advances, some updates, some innovations, some of them having to do with the medicines themselves and new formulations and new technologies, some of them having to do with delivery systems and strategies for engaging, initiating, and retaining patients, and some of them having to do with very timely adaptations to the current COVID-19 pandemic crisis. So here are my disclosures. I think of most relevance is that I've done some consulting for Alkermes, which manufactures one of the medicines, extended release naltrexone Withdrawal, that I'll be talking about today. I hope that you find that I'm not biased because of that, but you'll have to be the judge. Here are the learning objectives. And here's an outline of what we'll be talking about today. I'm going to spend a little bit of time talking about the basics of MAT or MOUD. I think that'll be old hat to many of you, but I just want to make a review to make the case that the FDA medications for OUD are the standard of care, and they have well-established effectiveness and utility. But then I want to talk about how to take those basics and go a step further. What's coming up? What's in the pipeline? We'll talk about some new medication formulations and dosing strategies having to do with new products, either on the market or soon to be on the market, some R&D in the pipeline, and dosing strategies. We'll talk about delivery strategies, how to use telehealth, how some other adaptations to the current public health emergency have changed the scene, both in advantageous and disadvantageous ways, and talk about where in the cascade of care we might have improvements for initiation, for retention, and for engagement. Talk about the emergency department, talk about medical hospitals, talk about the criminal justice system, talk about strategies to get people onto medication with less delay, with the hope that that will get people maybe not so much across the finish line, but at least to the starting gate more quickly, and talk about some retention strategies for assertive approaches that include family involvement and assertive community delivery. So let's start with a little bit of the review of the basics. Again, most of you will have heard this. This will be old hat, but there are 3 FDA-approved medications for the treatment of OUD, methadone, buprenorphine, and extended release naltrexone, and they are, or at least should be, considered the standard of care. And I'll show you a little bit about data for effectiveness, but these should form the basis, the cornerstone, a central element for the treatment of OUD in all circumstances. Not that they are curative, don't want to oversell. We certainly don't have the cure for opioid addiction or any kind of addiction, and I don't expect that. But we know that the effect size and the impact of these medicines are central, and patients do much better with them than without them, and especially so when integrated with a full spectrum of a comprehensive holistic care that includes psychosocial treatments, counseling, therapy, rehabilitative strategies. There's various ways, various nomenclature, various language that's used. We've talked about MOUD, or medications for opioid use disorder. That's the latest bit of jargon. An older nomenclature is MAT, medication-assisted treatment. That's perfectly fine. I like the term relapse prevention medication. And sometimes people even joke that, why would you say it's medication-assisted treatment? We don't talk about medication assisting the treatment of diabetes or hypertension. So as a bit of a clever turn of phrase, maybe we should be talking about counseling-assisted medication. Either way, the idea being that we have these medications and they have a central anti-addiction function in the treatment of OUD. Now, there are decades and decades of study and research about the impact of these medications. We certainly don't have time to cover it all, but just as a quick summary, here is a partial list of some of the well-established outcomes that have been demonstrated again and again about all three of these medicines. MOUD improves outcomes for the treatment of OUD as demonstrated by decreased rates of drug use, decreased rates of overdose, decreased mortality. That's an important one. We prefer people not to die, right? Increased treatment retention, decreased criminal behavior and recidivism, decreased rates of transmission of important infectious diseases linked to injection drug use, including HIV and hepatitis C, decreased hospitalization, and that includes decreased medical hospitalization, decreased psychiatric hospitalization, decreased detox hospitalization, increased employment, decreased homelessness, improvement in comorbid psychiatric conditions, improved birth outcomes for pregnant and postpartum women, and their infants. And for those of you who are thinking about healthcare economics, even if you're not interested in the warm and fuzzy patient outcomes that we talked about, decreased downstream costs. So over and over again, this has been examined. We have 60 years of experience with methadone. We have 20, 30 years of experience with buprenorphine. We have 10, 15 years of experience with extended release naltrexone. So the case is relatively clear from the point of view of the research. Just a quick refresher about mechanism of action. We could spend an hour on this slide. We certainly don't have that kind of time, but just to remind you that all three of these medicines work at the opioid receptor in the brain, and God gave us an intrinsic opioid receptor. Its usual ligands are the endorphins, the enkephalins. That is, that there is a nuanced, micro-balanced opioid transmission and signaling system in the brain. Presumably, God gave us that not so we could be better heroin addicts, but rather for purposes of reward signaling and reinforcement and pain and anxiety relief. But those are the places where the addiction takes hold, and it's the reinforcing properties of using street opioids and their effect on the opioid receptor, where the effect is to hijack the built-in opioid signaling system, and it is also the mechanism whereby all three of these medicines work. So just to go through it briefly, we have the term agonist and antagonist, which I'm sure you've heard. Agonist means a turner-oner at the receptor. An antagonist is a turner-offer at the receptor, and a partial agonist is a part turner-on or part turner-offer, kind of a hybrid. And methadone works as a full agonist. That is, it fully turns on the receptor. In a sense, it substitutes activity in a safer, medically supervised way for the intrinsic effect at the opioid receptor. And what this slide shows us is along the horizontal axis, the dose of medication. So it goes up from left to right, and along the vertical axis, the activity at the opioid receptor. And in the red line, the full agonist methadone, essentially the message is the more you get, the more you get. As dose of methadone goes up, there is increased activity at the receptor. And so all the things that you know about that opioids do, more of the agent, more of the medication does more of that. So it increases the side effects at first. And over time, the goal is, as the person who is a good candidate for methadone, and for all three of these medicines, it's not that everybody is equally a good candidate for all of them, but we're looking at what is the operational target for the person who responds well. And when a person responds well to methadone, they have enough opioid tone that their hunger or their craving or their drive to seek further illicit opioids is quenched. Now you see that the curve plateaus at 100. That's because at 100% you've got no more receptors to fill, but it's also that at 100% you've essentially overdosed, and respiratory depression causes an overdose and death. So somewhere along about 70, 80, 90% for the accommodated, tolerant patient. And that's a key point, because methadone, unlike heroin, is short-acting. Heroin is impure. Heroin you have to hunt for and take frequently. Heroin is not supervised in a medical way, but methadone of standard dose, standard purity, under standard medical supervision, somewhere after the person accommodates to the side effects. So over time, they're tolerant, they're not getting high anymore, they're not sedated, they're not feeling cognitively impaired, they don't have the euphoric effect. Those things go away over time, but a sense of fulfillment for the compulsion to seek further opioids is satisfied. The hunger is quenched. And so the person says, that's enough, and I don't need to keep seeking further opioids. Doesn't work for everybody. Different doses for different people. So we've learned over time that a minimum effective dose of methadone is probably 60 milligrams plus. 80 milligrams plus is very typical. Some patients even need 100, 200 milligrams, 200 may be an outlier. So there's a spectrum of dose at which people respond. There are some people whom the dose that is required to keep them from craving opioids is so high that the side effects are limiting, so that they're sedated, and that's not necessarily a good candidate. But for the person who's a good candidate, the sedation has gone away, the euphoria has gone away, they've accommodated to the side effects, except for maybe some inconvenient side effects like constipation, which often don't abate, but they've accommodated to most side effects, and they feel satisfied such that they're no longer seeking opioids. One disadvantage is if they do use opioids on top of methadone, they can still have an additive effect and are still vulnerable to overdose. But when they are not doing that, and they do that at much lower rates, it's a very successful treatment. And by the way, it's the one that we have the most information on, the one that's been around for the longest, as I said, 60 plus years, since the 1960s in the US. And it's the one that has probably impacted the most people's lives and helped the most people of these three, mostly because of the duration of its availability, helped the most people of these three to recovery. Let's talk for a second about naltrexone. It's the green line. It's an antagonist. It's a turner-oner. It blocks the receptor and gives no opioid feeling. So you see that the line stays at zero even as dose increases. And the way it works, again, for the people for whom it works, and as I said, none of these work for everybody, but for the people for whom it works, they're blocked from feeling the effects of opioids such that the reinforcing or rewarding properties stop, and there's no point seeking further opioids. Why would I take opioids if they can't get me high, if I can't get the feeling? There is the advantage of extended release duration. It's a once-a-month injection. There is a disadvantage that there is an induction hurdle, meaning it's a little tricky to get people onto it. It takes 7 to 14 days after last use of an opioid to be able to get onto the medicine to avoid what's called precipitated withdrawal. So it's easiest to deliver in, say, a residential setting where you have control of the environment and can supervise people over time during the period where they're having to stop opioids and have increased cravings and keeping them from having access. It has maybe an advantage or a disadvantage, depending on how you see it, that it doesn't have intrinsic opioid properties. Some people see that as a negative because people appreciate those intrinsic opioid properties, the minor opioid feel that you might get from buprenorphine or methadone, which might be a boon for retention, a boon for reinforcement. But other people might say, well, you don't want to encourage people to have a reinforcing feeling of opioids. Isn't that the whole point? I don't think there's a right answer to that. I think that all three of these medicines provide an appropriate approach for different kinds of people, and all of the pros and cons, like any medical strategy, take individual patient and clinician choice to weigh the pros and cons. Buprenorphine in the yellow line is a partial agonist, as I say, a part turner offer, a part turner oner, and it has this interesting intermediate effect. Early on in the curve towards the left, you have the same phenomena of the more you get, the more you get. As the dose increases, people have more activity at the opioid receptor, again contributing to the feeling of quenching of the thirst or satisfying of the cravings for opiates so that they're no longer feeling compelled to seek out illicit opioids. But then there's a plateau or a ceiling effect where it flattens out at around 40% or so intrinsic activity at the opioid receptor. And what that means is beyond a certain dose, somewhere in the range of 24 milligrams, maybe 32 milligrams for some people, maybe 16 or 20 milligrams for some people. Beyond a certain dose, you don't really get much more. It plateaus. And so that has certain advantages in terms of safety and accidental ingestion or risk of overdose. It has another interesting property that because it is so tightly bound to the receptor, it displaces other opioids. And there it has a partial blocking effect because using other street opioids, say oxycodone or heroin on top of it, if you're at a high enough dose, again, in the 16 to 24 milligram range for most people, you don't get an additional opioid effect. You don't feel an additional high. So there's kind of a hybrid between the antagonist and the full agonist. Anyway, as I say, we could spend a lot of time on that, but let's move on. And many of you know a lot of that. Their different delivery settings are interesting. It's not just the biology, but it's also where these medicines are prescribed, where they are delivered. Methadone, as you know, is only available in highly regulated specialty OTP programs. And so certain federal and state level regulations and licensing pertain. They tend to be separate from other general medical and even specialty addiction care settings. There are strict regulations about daily supervision of dosing. Patients need to start attending 6 days a week and only gradually earn what are called take-homes, that is home dosing that they can do on their own with time and progress in treatment. When we get to talking about coronavirus adaptations, we'll talk about how some of those rules have been temporarily relaxed by the FDA. One of the advantages in terms of delivery is that you can initiate it on the same day that a person last used short-acting street opiates such as heroin. So if you're intoxicated today, trying to seek care to get off of heroin, I can give you methadone today, and that's an advantage in terms of not having to delay initiation of care. Buprenorphine is available in any healthcare setting, but can only be prescribed by a healthcare practitioner that's done a certain amount of certification training, sometimes called an X waiver or a SAMHSA a buprenorphine waiver. And it can be delivered once the practitioner has that training in any setting, not just in a highly regulated specialty setting the way methadone is. In an office-based setting, that's sometimes called OBOT or office-based opioid treatment. But what that means is there's more transportability, if you will, in terms of broad dissemination. You can't give it right away the same way you can with methadone because it can cause precipitated withdrawal. You have to wait until a person has started to experience some degree of withdrawal to avoid precipitated withdrawal. That typically has been thought of as 6 to 10 hours after the last use of a short-acting opioid like heroin. But now in the current fentanyl environment, people are finding that because fentanyl stays in the system a long time and is highly, highly potent, as you know, that may prolong, and some people are now finding that you have to delay initiation with buprenorphine in the context of high prevalence fentanyl areas, perhaps as long as 24 or even 36 hours. Extended release naltrexone does not have any of the limitations of either specialty setting or specialty training. It can be given in any healthcare setting without restriction, but it does have the difficulty of getting over what we call the induction hurdle, because if you give it to a person who is tolerant or physiologically dependent on opioids, they can have precipitated withdrawal. So you need to delay 7 to 10 to 14 days after last opioid. And if you add in the time for detox, if an opiate like buprenorphine is used for withdrawal management or detox, that can extend the initiation delay time to 12 to 18 days after the last use. Obviously, that's a problem in terms of keeping people in care, especially after people are over the withdrawal management. They're no longer on any protective opioids, and they have to go a certain amount of time enduring cravings, but without having the medicine on board. And so you can see why that might be easier to do in a residential setting where there's better control of the environment and restriction by confinement from access to opioids. So which is better? The answer is yes. All three of them are very highly effective medicines, and there is no real answer in a horse race that one is better than the other. There have been comparative studies, and essentially the answer is that all three are good. Average outcome is about the same, but there is more focus and should be more focus on learning about individualized, patient-centered, customized treatment matching strategies. In the absence of any one of them being particularly better in aggregate, patient preference and family preference goes a long way, right? You want to encourage people to do a thing that they're invested in. Presumably that will increase adherence. The principle of try something else if what you tried before didn't work is certainly an important one. And when patients have difficulty with one of the medicines, we aspire to a setting in which they could have access in one-stop shopping in one place to all three so that you could go through serial trials. Patients might have different side effects, one from another, and they also might not just have real side effects. They might have imaginary or anticipation or misinformation about side effects, but that certainly affects their choices. The long-acting duration of monthly injectable extended release naltrexone is an advantage to some people, especially those that might have adherence difficulties with daily medicines. But as we'll talk about later, buprenorphine is now available in an extended release monthly injectable form. So that's a big advance. Methadone and buprenorphine are both intrinsically reinforcing, by which I mean that people like the opioid feel. You might argue, well, why are we wanting people to crave medicine or to be drug seeking? Isn't that exactly the opposite of what you're trying to do with helping people into recovery? Well, that's one way of looking at it. But another way of looking at it is that, listen, the advantages of abstinence and recovery don't come quickly. They come slowly. And in fact, many people feel worse before they feel better in early recovery. So perhaps liking your medicine in order to encourage you to keep taking it is not such a terrible thing. So you see different perspectives there. Methadone and buprenorphine both relieve withdrawal early on. Naltrexone, not so much. And as I say, you have to delay the initiation of naltrexone. All three of the medicines relieve cravings, but methadone and buprenorphine quicker than naltrexone. Some patients are surprised by that experience, and they say, well, I get the idea that I won't be able to use and I'll be blocked, but I understand that methadone and buprenorphine, since they relieve withdrawal, relieve cravings, and then they're surprised to see, although with some delay, that naltrexone also relieves cravings. There's more familiarity in the field with methadone and buprenorphine. That's a plus and a minus. You know, the reputation precedes both of those medicines. And for some people, the reputation is a good thing when they actually know the facts. For other people, there's all sorts of false information and the reputation turns them off. More and more now, people know more about naltrexone, and increasingly they will also know about the extended release buprenorphine formulations that we'll talk about. Anyway, the most important thing in the comparison, as far as I'm concerned, is I'm happy to have more choices for my patients, more tools in the toolbox, so I can work with an individual patient about the pros and cons and their personal success. And I look forward to a day when there aren't just 3 FDA-approved medicines, but 4, 6, 10, just as there are many antibiotics, just as there are many antihypertensives, just as there are many antidepressants, so that I have more choices for patients and more individualization. And I think that day is gradually coming. You should know about state-of-the-art consensus guidelines issued by the American Society of Addiction Medicine. This document, the National Practice Guideline for the Use of Medications in the Treatment of Addiction Involving Opioid Use, first came out in 2015. It recently underwent a focused update this year in 2020. I was privileged to be part of the guideline committee in formulating this document and its revisions. We don't have time to go over in detail. I will just bring to your attention some of these areas in which it's been updated in the 2020 focused update. One point that was made is that if a patient declines or does not have availability of psychosocial treatment, that should not preclude or delay pharmacological treatment. Certainly, we might prefer therapy and counseling and mutual help, but if it isn't available or the patient declines it, treat with medicines anyway, because that's life-saving and that can help patients get to recovery and to improved outcomes. When people first started using buprenorphine, we used to be very worried about precipitated withdrawal, and we did a lot of careful in-office supervision of initiation, or induction as it's sometimes called, for buprenorphine. Now, as we've gotten more familiarity, we understand that if we give patients instructions, they can start it at home fairly safely. And so most initiations of buprenorphine are now home-based with instruction. For pregnancy, the mono product of buprenorphine without naloxone, if you recall the brand names, Suboxone has the naloxone additive, Subutex, as it was initially called, did not. Subutex, the mono product, was initially what we used exclusively in pregnant women because of some concerns about toxicity to guinea pig fetuses. With further examination, the experience now is that the combination product is safe and effective, even though there's still some warning, even though this practice has not been as broadly accepted. Obstetricians are increasingly accepting that the combo product is fine. Initially, when we were first starting to treat people with buprenorphine and they needed pain relief during surgery, we would stop it and switch perhaps to full agonist opioid analgesics. Now we've learned that you can continue buprenorphine or methadone straight through and add other opioid pain relievers on top of it. And both surgeons and addiction practitioners such as myself have learned some of the nuances of that. Oral naltrexone, we don't even really talk about anymore. It's the daily pill form of the antagonist naltrexone. Most patients have adherence problems with it. It's too easy just to discontinue. It doesn't work as well in the bottle. Imagine that. And so unless you can get people to take extended release monthly injectable naltrexone, oral naltrexone, except under very limited circumstances, like when you use motivational incentives or contingency management, is generally not used in most common practice. And then another important point, and we'll come back to this when we talk about advances in delivery systems, is the directive to the field that the criminal justice system is a very critical target population and nexus of treatment. And all 3 of these FDA-approved medications must be, should be, need to be available for all patients in the criminal justice system. both continuing it during incarceration and detention, initiating it during incarceration and detention, and continuing it in community transition after detention. So that's it, right? Just give people MOUD and all will be well, and we're done, right? If only it were that easy. And here's a kind of a silly cartoon of the monkey on your back, but we found it in your brain. And, you know, if only we could curatively reach in with a teeny little tweezers and fix the mu opioid receptor in the patient's brains, but it isn't that easy. The medicines are good, but they are not curative, and there are many barriers to initiation and retention and success. And so we're going to spend the rest of the time talking about what do we got in our toolbox, not just these 3 excellent medicines, but how to spruce it up, take it to the next level, and advance our application in real-world delivery. This is an important conceptual framework, the OUD cascade of care. This is important work that was published in the last couple of years. And we talk about cascade of care in a variety of chronic conditions in which we think about different points along the continuum of access and care in a patient's journey. So primary prevention is thinking about the general population, 300 million people in the country, who's got vulnerability, who's got increased risk factors, how do we prevent them from being exposed to opioids and developing the disorder. Secondary prevention is thinking about people who've been exposed to opioids, so some subset of the general population, and we think that's somewhere between 10 and 100 million people who've been exposed to opioids but haven't developed a disorder. Anybody might get opioids for a medical condition. And secondary prevention is how do we prevent them post-exposure from continuing and escalating use and developing the disorder. Then there's the group of people who have OUD. And in the US, that's somewhere north of 2 million, maybe 2.5 million people. But of them, as we proceed to the right along this cascade of care, how many have been identified? How many have been diagnosed so that they can be introduced into care? And of those that have been diagnosed, how many have been engaged in care? And of those that have been engaged in care, how many have been initiated into standard of care MOUD? And of those that have been treated or initiated onto MOUD, how many are retained? And a nice benchmark is 6 months or more. And of those that have been retained for that benchmark of 6 months or more, how many have gone into remission, achieved abstinence, and embarked on a lifelong journey of recovery? And one of the analogies to this cascade of care, say, is the HIV cascade of care, or the diabetes cascade of care, or the hypertension cascade of care. And in public health circles, we tend to think of the rule of 90%. We aspire in a public health framework and strategy to have the transition along these cascades of 90% of the left status progress to the right status. We would like 90% of those who have OUD to be diagnosed with OUD. We would like 90% of those diagnosed with OUD to be engaged with care. We would like 90% of those engaged in care to be started on medicines, et cetera, et cetera. And that's reflected by the red bars, the aspirational strategy of what an optimal public health strategy would achieve. The blue bars, unfortunately, are the real world of current estimates. And you can see we're not doing that well. We can do a lot better. In fact, the word pathetic even comes to mind, if you pardon my editorialization. And this is just a kind of a thought of what ought to be our benchmark for the strategies that we're going to talk about. What would we like to achieve? What are our aspirational goals for population health, being able to increase initiation, increase retention, and improve outcomes? Here's some data for substantiating the claim that OUD medicines, MOUD, are effective. And this is very novel in addiction treatments to have this long-term outcome. This is 5-year outcome from initiation of medicine. And although in cancer treatment and other medical treatments, we talk about 5-year, 10-year, 20-year timelines for outcome and prognosis, that is rare to have. So to be able to look here at 5-year outcomes in addiction medicine is really quite unique. And this looks at what happens to people over time who start on either buprenorphine or methadone, and 5 years later, where are they? First, the bad news. On average, people are not in treatment with medicine. So at 5 years, 39% of the time people have spent in methadone treatment in this study. 14% people have spent in buprenorphine treatment. Very few people were on naltrexone treatment because this was done several years ago. But notably, 47% of the time, people were not on any medicine. But to the extent that people were on medicine, and you can see the lower rates of estimated days of opioid use per month, not much different between buprenorphine and methadone. So the important thing is not which medicine you were on, but if you compare it to the higher line where people were on no buprenorphine and no methadone, the biggest impact is being on one of those medicines. If you were on either of those medicines over the course of these 5 years, you did dramatically better, substantially better in terms of days of opioid use, rates of remission, rates of abstinence, and emergence into the journey of recovery than if you were not on either of those medicines. So again, that's what we're looking for. How can we maximize initiation and retention on FDA-approved MOUDs to make the impact? So now let's talk about these advances. The first set of advances I want to talk about are medication advances in terms of the technology of the medicines and dosing strategies. So here is some evidence that tells us that dose is important. Got a curve here in the open triangles for methadone and in the shaded diamonds for buprenorphine. And although this is not prospective randomized data, it is retrospective data for naturalistic treatment, looking at retention rates according to dose. And the methadone dose message is relatively old news. Remember, I said before that we look at doses in the 60 to 80 milligrams a day as being relatively threshold doses for minimum effective dose. But it goes up with dose. The higher your dose on average, not everybody needs a higher dose, and some people have higher side effects with higher doses, but on average, retention and outcomes are improved with higher dose. Well, it also turns out that's true for buprenorphine, and that is relatively new information. Early on in our understanding and adoption of buprenorphine treatment, we tended to adopt a dose-sparing strategy, thinking less is more. Well, it probably turns out that less is not more is more. Yes, you increase the risk of diversion, and you can't prove that if you give people higher doses, they aren't taking half and selling half, so that's an unintended consequence. But if patients are taking higher doses, generally they are retained better and doing better. And so one approach to poor retention, to continued use, to treatment dropout with buprenorphine treatment, as it is with methadone, is to increase the dose, being mindful of side effects. Here's another important advance, extended release buprenorphine. So just as we've had since 2010, extended release naltrexone for opioid use disorder, since about a year ago, we've had extended release buprenorphine for opioid use disorder. The brand that's currently commercially available is called Sublocade. And as I'll show you in a second, there's another one on its way that should be available early next year. But this particular formulation is a 1-month shot. You can see a picture here of it being administered in the subcutaneous tissue of the abdomen. It's an easy injection. It stings going in and leaves a little bit of a lump, but that gradually resolves and patients quickly accommodate to that. It's available in 2 dosing strengths. We start people usually on 300 milligrams, and sometimes we keep them on 300 milligrams, and sometimes we decrease them. down to 100 milligrams after several months. There's no exact translation from monthly milligram doses to daily sublingual doses. It's individual, and it has to do with your metabolism, and it has to do with your tolerance. But roughly 300 milligrams is probably equivalent to 16 to 24 milligrams of daily sublingual, and 100 milligrams is probably equivalent to 4 to 12 milligrams, but again, with individual patient variation. Here you can see in the data that blood levels build over time. So as people stay on it, they gradually increase. Sometimes we have to add some supplemental dosing early on of daily sublingual if people aren't getting enough of a dose while it builds up in their system, but that's relatively minority. It has to be ordered through specialty pharmacies, so that's a bit of a barrier working out the contracting and the approvals and whatnot. And it's relatively new, so some of you will have had some experience with it, others of you will not have, but it will be increasingly disseminated. We'll see it gradually, increasingly adopted. I've now treated several hundred patients with this, and as you can imagine, there is an advantage for adherence. The target patient is someone who's had a good response biologically to buprenorphine, but may have difficulty staying on it, may have difficulty, and so it's a nice enhancement to adherence. Coming out probably early next year in 2021 for commercialization is an alternative formulation of extended-release buprenorphine. It will be brand named Brixadi. It will have slightly more variations of dosing strength. It will be available in a 1 month and a 1 week duration and 4 strengths of each. So although for the general physician, that might be maybe a little bit too complex, for the specialist, it might be more available choices to be able to custom dose. The Sublocade formulation requires having somebody on sublingual dosing for at least 7 days as a lead-in, because the Brixadi will have 1 week formulation and it's not as much of a commitment. You can essentially start after 1 dose of sublingual right to the 1 week. It may have an advantage in terms of a smaller volume of injection, and so you have site flexibility. Because of the larger volume, everybody's got an inch to pinch around their middle, and the Sublocade needs to go in abdominal subcutaneous tissue, but you can give the Brixadi subcutaneously, not just in the abdomen, but in the thigh, in the arm, and other places. And so for some patients, that might have some advantage. But the logistics are unknown, right? It isn't commercially available. It's only been used in research applications. And so we have more to learn about its applicability and its acceptability and patient success. But the research is good so far. And again, more tools in the toolbox is a good thing, being able to custom treatment match. Here's just some comparisons between the two products, as I already talked about. Some questions are, what do you do when patients don't respond as well to extended release MOUD? And I broaden this from saying XR bup or XR naltrexone to think about the broad category of both naltrexone and buprenorphine as deliverable in patient choice of one or the other extended release monthly injectable formulation. It's good to have choices, but we're still learning how do we address individual variation and response. We're still learning what happens as patients' blood levels go down over the course of the dosing cycle. That is, early on, your blood levels may be higher. By week 3, by week 4, it may be starting to ebb and be losing its effectiveness in blockade, losing its effectiveness in removing cravings. And we don't have the research now in the era of fentanyl to tell us what optimal strategies are in response to fentanyl. This was not an issue before 2015, but now in some urban areas on the East Coast and the West Coast, all there is on the streets, at least that's what my patients say, all there is fentanyl. And so what does that mean in terms of its potency and the response to these medicines. Some answers include increased dosing frequency. So it's become relatively common, for example, with extended release naltrexone, to give it every 3 weeks for patients who say by the third or fourth week their cravings are increasing, or that they can overcome the blockade if they try. Is that an appropriate strategy for extended release buprenorphine? We don't know yet. And there hasn't been published research on that. So people are going to begin to investigate that, and we're going to begin to see, but it's a natural extension of a dosing strategy that we've learned about. What about the idea of adding supplemental daily doses? I spoke about that a little bit. You can add oral naltrexone to extended release naltrexone. If the effect is not adequate, you can add sublingual buprenorphine on top of monthly injectable extended release buprenorphine. And again, thinking about individual patient response to customize a maximum reduction in craving and alleviation of the temptation to use. There are some people who would even talk about combining extended release naltrexone and sublingual buprenorphine, or extended release naltrexone and extended release buprenorphine. That hasn't been widely described as a strategy. It seems somewhat contradictory, but again, two different mechanisms targeted at the same disease state. Could there be something there? Again, awaiting further exploration. What about if we had these medicines that would last even longer than the current extended release formulations? The advance from daily dosing to monthly dosing is certainly an advance, but what about if it would last for multiple months? What if it would last for 3 months, 6 months? Imagine even 12 months. So there's a lot of R&D going on in the pipeline for naltrexone implants. There is a buprenorphine implant called Probufene with 6-month duration. It hasn't prospered well in the market because it's relatively low dose. And so it's the equivalent of approximately 8 milligrams, which is insufficient dosing for most patients. But the proof of concept is there. What if we could get higher dose implants? There are numerous naltrexone implants in development, and the idea of longer duration and possibly higher blood levels would be, I think, important strategies. Things to think about are, well, what does it mean to have the procedure? Do you need surgical involvement? What does it mean to remove it? One of the interesting strategies is the idea of an implant that might be dissolvable that wouldn't need removing. And so all of these things are things that are underway in the lab. Don't hold your breath, don't buy stock yet, but coming, we hope, relatively soon. All right, let's talk about delivery strategies, because it isn't just about the medicine, it's about getting the medicine into people. It's about connecting people with care. And I want to think about a number of touch points, especially upstream from specialty care. So a patient gets to me, and if you guys are specialty addiction providers, a patient gets to you only after much distance, after many consequences, after several stumbles. And certainly the specialty care space is critical, but what if we could connect people to care upstream at opportunities where unfortunately they are insufficiently identified, but could be identified and initiated into the cascade of care? One thing that has certainly been a big theme, both broadly and now during the coronavirus epidemic, is the advantages of telehealth. And, there's a bunch of different possibilities in terms of reducing barriers to access. Patients find that transportation and stigma and the difficulties of accessing care in specialty settings to be barriers. But one of the things that home-originated telehealth is able to do is literally meet them where they are, including in their homes. I have found, for example, the advantage of being brought into the person's home as a close-up of their real-world environments, both in terms of the facilitators and the barriers to care. You can see what their function is like. You can see what their real challenges are like. For many patients, it's a very reasonable substitute. Some practitioners even say that their no-show rates have gone down and their engagement has gone up. I would say that for stable patients, I've had that experience. I would say for new patients or unstable patients, I think it's still not the same as having the real touch of in-person human interaction and the structure that might come with programmatic care, because it's difficult to get unstable patients into the habit of being organized enough to access care. And certainly lots of underserved populations don't have the technology easily available to be able to routinely access care. So lots of pros and cons, but more tools in the tool chest, I think, is a good thing. You may know that during this public health emergency, some of the prior restrictions on telehealth have been relaxed under the federal state of emergency. So HIPAA compliance has been downgraded, audio only has been permitted, and something called the Ryan-Haight Act, which limited in-person initiation for controlled substances, including buprenorphine, to requiring an in-person visit, have been temporarily waived. Just recently, those rules were set to expire on July 25th, but they've been extended by HHS another 90 days. So we'll see what happens in October when they're set to expire again. And many people are hoping that some of these relaxations will be held to be permanent because of some of the advantages. So we think that maybe audio only will not be permanently extended, maybe HIPAA compliance waiver will not be permanently extended, but maybe some of these things will be, and especially local and state restrictions on reimbursement or on Medicaid coverage or on home initiation will be permanently waived. There have been some relaxation of the OTP methadone take-home rules. I think the DEA will probably not extend those permanently, but in the meantime, when congregate care in specialty methadone settings has risk of infectious disease transmission, I think that those are advantageous. Here's an Upstream site. What about the emergency department? So patients come into the emergency department routinely with opioid use disorder for the medical consequences of that disorder, but not necessarily because they identify themselves as having opioid use disorder or want care for opioid use disorder. What do I mean by that? Overdoses, soft tissue infections, endocarditis, traumatic injuries, things that proceed as medical consequences. They come into an ED, appropriately, they get life-saving treatment, say naloxone, Narcan for an opioid overdose, life-saving, critical. We want that, but just a Band-Aid. And unfortunately, too often the OUD is not identified and patients are not initiated into care. So this is, and we're going to need to accelerate and move quickly, but this shows us that the idea of using the emergency department as a portal for treatment effective with initiation in the ED at the point of presentation upstream can be a good thing. And here's the same thing for hospital initiation. Patients come into hospitals for the medical consequences, or the psychiatric consequences for that matter, of opioid addiction. And unfortunately, opioid addiction is not identified and medicines are not necessarily initiated, but good research that has now been replicated repeatedly shows that if you identify the addiction, if you identify and initiate buprenorphine treatment for the OUD, you get substantially better outcomes. The same thing is true in linking people at the upstream point of identification in the criminal justice system. This is work from Mike Gordon and his colleagues at Friends Research Institute, where they have done this work with methadone, with buprenorphine, and with naltrexone. And the point being that if you initiate medicines behind the walls to criminal justice populations during incarceration, and then give them a warm handoff to continuation in the treatment, post-release transition to the community, you do much better than if you just give them a referral or if you don't start medications at all. Very critical, and this movement is sweeping the country, hopefully. Rhode Island has been a big pioneer, but other states, including the state where I practice, Maryland, is moving towards normalizing and mandating the availability of MOUD, all three kinds of MOUD, to patients in incarceration and at other touch points in the criminal justice system. We've got advantages and advances in withdrawal management. You may have heard of a relatively new medicine called lofexidine. It's similar to clonidine, probably no more effective than clonidine, but with probably a lower side effect profile. And one of its advantages is it has a specific FDA indication for opioid withdrawal. Clonidine, which we've used for years, is not specifically indicated for opioid withdrawal, so it's used off-label. And I think in the general medical population of general practitioners, having an FDA indication will lead to better adoption and better dissemination. Pregabalin has some advantages, and some people are increasingly use it for withdrawal management. And learning what the right strategy for fentanyl is a new area of investigation, because patients started on buprenorphine and naltrexone soon after fentanyl may have higher rates of precipitated withdrawal. So part of the question is, do you delay 24 hours to 36 hours, or do you keep powering through and up the doses to get through the precipitated withdrawal? And there are advocates of both of those approaches. One of the strategies for getting people onto extended release naltrexone will involve accelerated initiation. Remember, we talked about an induction hurdle that sometimes takes people 12 to 21 days from last use to get to naltrexone. What if we could compress that? One of the strategies is to avoid the use of opioids, including buprenorphine, and use non-opioid withdrawal management strategies, whether it's higher doses of clonidine, whether it's higher doses of lofexidine, whether it's pregabalin or benzodiazepines, but to spare opioids for withdrawal, accelerate the time and decrease the duration to get to naltrexone, with the notion that if you get them quicker, fewer of them will leave with cold feet, more will initiate on the medicine and have chances for success. And that's an active area of research. And here's just an example of one protocol that's been studied in an important research paper. I'm going to quickly go now to the end. We've got to end. This is just a picture of some work I've been involved in using mobile van delivery for treating young adults with OUD. In this case, a person's getting a dose of extended release buprenorphine, but we also use extended release naltrexone. And the idea is that young adults have difficulties with retention and adherence. So we go to them using some of the tricks borrowed from the playbook of assertive community treatment that you may have heard of with the treatment of schizophrenia and other chronic mental illness. We take the mobile van to the patient's houses, call them into the van. It's a disinfectable and controllable environment in these days of concern about infectious disease transmission with COVID. And so it's a home delivery model that doesn't necessarily require going into the homes where we might be concerned about transmission. So in conclusion, we got 3 very highly effective medicines. Each have their pros and cons, like any medicine, but all 3 are very good options. And the most important factor is getting patients onto one of these medicines and helping them stay in treatment. Initiation and retention are problematic. We got plenty of room for improvement in the cascade of care, but we're moving in the right direction. These medicines ought to be the standard of care. We got 3 current good choices. We got expanding choices, as I told you, with improved formulations and more formulations and better technology coming. The more choices we have, the better we're able to tailor medication and delivery setting to individual patients. Some patients need a lot of intensive support, structure, counseling, residential treatment, IOP, mutual support. Others do well with medicine alone, but the idea is to work with individual patients, find the approach that's tailor-made to them, and in an optimistic way, I can't emphasize enough that treatment for OUD works. We've talked about each of these advances. We're in the midst of a national crisis, as you know. Mostly you can't escape hearing about the coronavirus epidemic, but the epidemic of OUD and overdose death rages on and isn't going anywhere. We have these existing and emerging tools, but unfortunately, they don't have the levels of adoption and utilization that we need to aspire to. So being optimistic, using these tools, we're doing great work, but I hope that each of you will understand and advocate that we need to improve, we need to strive to do better, we have a moral obligation to do better because our patients' lives are at stake. And I'm going to stop, and I've probably run out of time, and I wanted to get a chance to do questions. Maybe we have time for one or two. Here's some hypothetical miracle cures. If only we could do the transplant of the opioid-addicted brain, not likely in our lifetime, but I think that it's an optimistic message that I want to leave you with, that we do have an expanding set of tools. And I thank you all for your commitment to these patients, because that's what's important as we strive to save lives every day. So I'll stop. If we have time for a question or two, let's do it.
Absolutely. Well, thank you, Dr. Fishman. And what a fascinating graphic. Brains, 25 cents. Might be worth a little bit more these days.
Inflation,
that's right. Well, we do have time for one question from the audience. This was the question that got the most likes, actually, or the most responses looking for an answer. Since buprenorphine is a partial opioid agonist, can a tolerance be developed?
Yes, patients can develop a tolerance, and sometimes we see that patients benefit from dose increase over time. Actually, it looks like dose increase early on is most related to therapeutic benefit. That is, not waiting, but getting patients up in dose right away. But yes, some patients develop a tolerance and need their dose increased early or middle or late. But the good news is that because it is so tightly bound to the opioid receptor, it continues to have, just as it has the partial agonist effect, the partial antagonist effect by blocking other opioids. So even if patients gradually need more, even before their dose is increased, they continue to have protection.
Well, thank you. And hopefully that answered the question for our audience. And unfortunately, we're out of time, but it was a fascinating presentation, Dr. Fishman. We appreciate your time being here. We appreciate our attendees for joining us for this session. Ladies and gentlemen, this concludes this presentation. Our plenary with Dr. David Smith will begin shortly. Thank you.